Hello, I'm Brendan McKenzie. Thank you for coming to this session. Today I'm going to talk about overdiagnosis. Is it possible that we are offering our patients too much medicine? I don't have any financial conflicts of interest to disclose. I will mention that I work for Loyal, which is a biotechnology company researching therapies for aging in dogs. Just a little bit more information about my background. I started with a master's degree in animal behavior, trying to be a primatologist, and after a few years of that, I switched gears and went to veterinary school at the University of Pennsylvania. Because I've always been interested in the relationship between research evidence and clinical practice, I then went on and did a master's degree in epidemiology through the London School of Hygiene and Tropical Medicine. I have been a clinician in private practice working with small animals for my entire career, over 20 years now. Most of that time at Adobe Animal Hospital, which is a small animal practice in the San Francisco Bay Area. I've always been interested in evidence-based medicine and the relationship, again, between science and clinical practice, and I am a past president of the Evidence-Based Veterinary Medicine Association. I currently also work for Loyal. We are studying therapies to hopefully reduce the health impacts of aging on dogs, and I also write an evidence-based veterinary medicine column once a month for Veterinary Practice News. Some of you may know me from SkeptVet, which is my online presence, and that is an advocacy platform where I talk about evidence-based veterinary medicine and applying good scientific research evidence standards to all veterinary therapies. I have a link here, which I will mention again at the end of the presentation. This is for you to hopefully be able to get some resources to help you in your own understanding of the topic we're going to talk about today, which is overdiagnosis. Cured yesterday of my disease, I died last night of my physician. This is a very old quotation that illustrates something which I think we're all well aware of, which is that medicine can be dangerous. It is possible for us to do no harm. And the dictum, primum non nocere, right, do no harm, is something that we're all taught at some point in our clinical training because we are aware of this. Overdiagnosis is a type of harm I want to talk about. So what is it? Let me start with an example, and that might help to make it clearer when I get to the formal definition. This is Tuck. Tuck was a 5-year-old neutered male Labrador who presented with acute left hind limb lameness. A good thorough physical exam found effusion and a drawer sign in the left stifle, and given his signalment, clinical presentation, imaging, it was clear that he had a ruptured craniocruciate ligament. The recommended therapy for this was a TPLO surgery, and he was referred to a specialist for this purpose. The specialist conducted some preoperative blood work, found the CBC was normal, but did find a moderate elevation of the ALT. Just to investigate this, an ultrasound was done, and there were a few indistinct nodular areas throughout the liver. In order to make sure that this was not something that was a concern for anesthesia or potentially neoplasia, a biopsy was done by ultrasound-guided TrueCut to identify these lesions. The biopsy results fortunately came back benign nodular regeneration, so of no clinical significance. Unfortunately, Tuck bled to death as a result of his biopsy procedure. The cause of death was officially listed as complications from the biopsy, but the real cause of death for Tuck was overdiagnosis. And I will point out that, though this is a simplified version, this is an actual case that was sent to me by someone who had listened to one of my lectures on the subject of overdiagnosis. So what is the formal definition of overdiagnosis? This is the correct diagnosis of a disease which is truly present, but which is never going to cause clinical symptoms or death. In other words, it is correctly diagnosing something that is irrelevant to the patient's well-being. There are a couple of ways that overdiagnosis can happen. One of the most common is through screening, where we conduct diagnostic testing on asymptomatic individuals and we find disease that is not clinically relevant. Another way that overdiagnosis occurs, something that's probably more common in human medicine, is the expansion of disease definitions, where we begin to treat something as a disease which was previously considered part of normal variation. In humans, for example, the standards for what constitutes high blood pressure have changed, and so people who are now treated for hypertension would previously have been considered normal or pre-hypertensive. In veterinary medicine, one possible example of this is the designation of stage 1 chronic kidney disease, where we are using more sensitive tests like the SDMA test to identify kidney disease at a preclinical stage. The identification of incidental lesions on imaging is another common cause of overdiagnosis. That is to say that we find lesions which may represent true disease, but which were not causing clinical symptoms. And if these never go on to cause clinical symptoms, then their identification and treatment is of no value to the patient. I want to be clear about what overdiagnosis is not. Overdiagnosis is not the same thing as misdiagnosis, as getting the wrong diagnosis. false positive tests or incorrect diagnosis is not the same thing as overdiagnosis. These are separate problems. Similarly, overdiagnosis is not any diagnosis. If you have a patient who has clinical problems attributable to a disease and you diagnose that disease, that is not overdiagnosis. That is appropriate diagnosis of a clinically relevant problem. Overtreatment is related to overdiagnosis. Overtreatment is simply treatment which provides no benefit to the patient or which does more harm than good. And overtreatment can occur even without overdiagnosis. If you treat a patient too aggressively for something that is truly present and clinically relevant, you could end up harming the patient more than you benefit them. But any treatment that is given on the basis of overdiagnosis is by definition overtreatment. If the diagnosis is of something that is never going to be clinically significant to the patient, then the treatment cannot be beneficial to that patient. So how do we identify that overdiagnosis has occurred? You've probably already picked up on the key problem here, which is that we cannot know in advance in any individual patient when we've made an overdiagnosis as opposed to an appropriate diagnosis. We don't know that that disease was never going to be clinically relevant, except in retrospect. The other way that we look for overdiagnosis is through epidemiologic data. This can't tell us if an individual patient's diagnosis is an appropriate diagnosis or an overdiagnosis, but it can give us a sense of the extent to which overdiagnosis is occurring in a population. There is a lot of attention being paid to overdiagnosis right now in human medicine. There are conferences dedicated entirely to discussing this problem. There are special features in medical journals that regularly present examples of overdiagnosis or evidence discussing overdiagnosis and how it can be minimized. There is a wonderful organization called Choosing Wisely, which is a consortium of specialty colleges that have put together resources for physicians and also for human patients to try to help reduce overdiagnosis. These include lists of tests or treatments which are unlikely to be beneficial in many patients and which should be discouraged or used less often. So, what are we doing in veterinary medicine to address this problem? How are we handling the issue of overdiagnosis in veterinary medicine? Unfortunately, mostly we're not. There's very little discussion of this in the scientific literature, and there is very little effort to understand the extent to which overdiagnosis is occurring and how we can prevent it. So let me talk a little bit about how we know that overdiagnosis exists on a population level. The classic example of detecting overdiagnosis is when there is a change in the rate of diagnosis of a condition that is typically fatal, but there is no change in the population in the death rate from that condition. So if, for example, you see the incidence of a certain type of cancer increasing, and at the same time you see the number of people dying of that cancer increasing, there's very likely a true increase in the prevalence or incidence of that cancer. You're seeing more cancer and it's killing more people. But if you see a significant increase in the number of diagnoses of a cancer and you don't see any change at all in the death rate from that cancer, it's quite possible that what you're seeing is overdiagnosis. Perhaps a new test has come along or people have greater awareness of the disease, and so the diagnosis is being made more often in individuals who are not symptomatic and not destined to go on and experience the negative outcome of death. There are other possible explanations, of course. Sometimes you may have a new test or a new way of diagnosing a condition at the same time that you have a new and remarkably effective therapy, and you can then see more diagnoses without as many deaths. But that's something that we can tell from the literature. There are plenty of examples where this pattern shows up and does truly represent overdiagnosis. I know this is a bit of a complicated slide, but I think it has some important points to make, so let's talk through it quickly. Start by focusing on section B in the upper right-hand quadrant. This is an example of what we call screening and how most of us think screening works. Screening is the testing of asymptomatic individuals, people or pets who have no clinical symptoms from a disease, with the intention of detecting that disease at an earlier stage so that we can more effectively treat it. So at the top of this corner of the figure, you see an example of someone who's diagnosed with cancer at the age of 67. Previously asymptomatic, they become symptomatic and they're diagnosed with cancer. Then they eventually die of that cancer at the age of 70. With screening, we are able to diagnose this individual earlier, at 64 years of age, before they are clinically symptomatic, and because of this, we are able to treat them more effectively and extend their life. So they die at 71, they get an extra year of life because we detected the cancer earlier and treated it. And this is how most of us are used to thinking of screening. The problem is that screening, testing asymptomatic individuals, doesn't always work out this way. Let's shift our attention to section A in the upper left-hand corner of this. This is an example of a very similar case where instead of being diagnosed at 67, the patient is diagnosed at 64. But you'll notice that the outcome is the same. The patient dies at the same age. This may be because there's no more effective treatment when a diagnosis is made earlier than when it is made later. There are a number of reasons why this could happen. But screening has not benefited this patient. Hasn't done any harm, but hasn't benefited them either. Now let's take a look at section C, the lower left-hand quadrant here. Now this is a more worrisome situation. This is where instead of being diagnosed when they become symptomatic at age 67, the patient is diagnosed through screening before symptoms start at age 64. They do not benefit in the sense of having a better outcome. The age at death is still 70, so there's no benefit there. But during this extra period of time, from age 64 to age 67, they are being treated for cancer. They're experiencing the negative effects of cancer therapy, and yet in the long run, they don't experience a better outcome. This is a case where screening can actually do harm. The only thing we've accomplished by diagnosing this disease earlier is giving this patient longer to live with this disease and more side effects from treatment that did not ultimately improve the final outcome. The most worrisome issue with overdiagnosis and overtreatment is section D, the lower right-hand quadrant of this example here. In this case, the patient is diagnosed at age 64, again 3 years earlier before symptoms begin because of screening. However, the patient is treated aggressively for this cancer and dies from the side effects of the treatment at age 69, a year earlier than they would have died had they not been treated and had they not been diagnosed until symptoms began. An example of this, for example, would be something like doxorubicin causing cardiomyopathy in a patient with some kind of cancer that is being treated with that chemotherapeutic. You can actually make the outcome worse, in addition to giving the patient longer to live with an awareness of their disease and clinical symptoms of their disease. So we always think of screening as inherently benign and beneficial, but there are many cases in which it accomplishes nothing for the patient or actually makes the outcome worse. So how commonly does this really happen? Is this just an occasional thing, or is this a really serious problem? Well, one example is prostate cancer screening in men, using something called prostate-specific antigen, which is a blood test that will detect this protein that is released by prostatic cells, and it is sometimes a good indicator that prostate cancer is present. So when this was introduced, screening of asymptomatic men became a really common practice. And this is an example of the shift in the diagnosis rate once PSA testing came into play. Many, many more diagnoses were made of prostate cancer than before PSA testing was available. However, you will notice there is no improvement of any significance in the death rate. And this was an example of overdiagnosis from screening at an earlier stage. And in fact, the statistics that have since been compiled over several decades in men subject to PSA screening are kind of startling. Of the men diagnosed with screening, somewhere between 5% to 75%, depending on the population and the methods used, were actually overdiagnoses. These were men who were never going to be clinically symptomatic or affected by their disease. 25 or 30% of them would never have even known they were sick. Okay? 30 to 100 men are treated unnecessarily for every death that was prevented because of prostate-specific antigen. That's a lot of men who were treated for prostate cancer with a relatively small improvement in outcome. And for one death prevented, 1,000 men were screened, many of whom were then subject to additional testing or therapy. Now, the reason for this is partly because prostate cancer is often indolent and may be very slow growing and not become symptomatic. But this wasn't really understood when the only cases seen and diagnosed were those that were symptomatic. So this new test gave us the ability to diagnose the disease at an earlier stage, and it allowed us, unfortunately, to diagnose cases that turned out to be indolent and were never going to be symptomatic. That diagnosis and therapy then did more harm than good. A similar example that you may have heard of is the application of mammography to women under 50 looking for breast cancer. And this is something that generated quite a bit of controversy here in the United States a few years ago. More aggressive screening of younger and younger women led to a greater increase in the rate of diagnosis for breast cancer, but not an improvement in the number of women who died of breast cancer. And once again, the reason for this was because there was a significant rate of overdiagnosis. Somewhere between, again, 10 to 90% of women diagnosed by screening at this age were overdiagnosis, were women who had diseases that were never going to be clinically significant. 30% of them would not have had symptoms, and 2 to 10 women over a 10-year screening period were treated unnecessarily for every single death that was prevented. That's a lot of women receiving therapy for disease that was never going to affect them in order to, on a population level, achieve a fairly small improvement in the rate of death from breast cancer. One study in France in 2010 translated this into specific numbers and found that 30 to 37,000 women were overdiagnosed with breast cancer. So this was a very significant problem. Now, in veterinary medicine, I'd like to know if this is a significant problem for me and for my patients. How common is overdiagnosis? I think you know where we're going with this, right? Unfortunately, we don't collect that kind of data. Epidemiology is simply not at the state in veterinary medicine where we can say how commonly we are overdiagnosing our patients. So one question that often comes up in the context of overdiagnosis is, what's the harm? Even if I diagnose a disease that's never going to be clinically significant, how is that harmful to the patient? Well, there are a number of ways that overdiagnosis is harmful. One that's discussed in human medicine frequently is financial harm. For example, all of the resources that go into testing and follow-up testing and treatment when a condition is overdiagnosed are wasted. They're not actually benefiting patients at all. This increases healthcare costs, which in turn decreases the availability of healthcare. This is, of course, particularly a problem in the United States where I live, where healthcare is not a universal right. But in many cases, in other places, the resources that go into providing healthcare are siphoned off by overdiagnosis, by the diagnosis and treatment of patients whose disease is not going to ever be clinically significant. In veterinary medicine, overdiagnosis raises the potential for economic euthanasia. If we spend our clients' resources on testing and treatment that doesn't benefit the patient, those resources may not be available when there is a potentially treatable condition and they no longer are able to treat it, and we're faced with euthanasia because treatment is not affordable. Financial harm has been studied in quantitative detail in the United States and in other places, and it is a tremendous problem. $4 billion, for example, in each year were spent on diagnosis and treatment related to overdiagnosis of breast cancer through mammography. The treatment of mild hypertension, which is probably in many cases not going to lead to better outcomes for patients, adds $32 billion a year to healthcare. And the estimated total cost of unnecessary care in the United States, much of which is due to overdiagnosis, is $200 billion a year at the time that these statistics were compiled, which is several years ago now. So financially speaking, this is a significant drain on economies and on healthcare resources. Again, what do we know about the cost of overdiagnosis in veterinary medicine? As you can imagine, next to nothing. Obviously, I'm a clinician, so while the financial consequences of overdiagnosis are certainly significant, I primarily am interested in what this does to my patients. Is this harming my patients? And there is, unfortunately, good evidence that overdiagnosis is harmful to patients. There are two ways this can occur. One is simply the harm of the diagnosis itself, and in humans, this often translates to significant anxiety or psychological harm. And then, of course, there is the harm directly to the patient from testing and treatment that isn't necessary, that isn't beneficial, but is caused or instigated by overdiagnosis. Tuck was an example of this. This is a dog who received some testing that led to a benign diagnosis that had no clinical relevance, but unfortunately suffered a fatal consequence from the diagnostic process. In the case of prostate cancer screening with PSA, we know that, for example, 86% almost of men who were diagnosed with a positive PSA underwent at least one prostatic biopsy, sometimes more. And those biopsies are not benign. A high proportion of those biopsies have complications ranging from pain to hematuria to other kinds of urinary tract dysfunction. So this is a significant amount of direct patient harm occurring from this screening test. Many men who are diagnosed with prostate cancer that is indolent and never going to be clinically significant nevertheless underwent surgery, prostatectomy, or radiation therapy, or other aggressive treatments once that cancer was diagnosed. And a large proportion of these men experienced the kinds of side effects that follow from these procedures: sexual dysfunction, difficulty urinating. A relatively small proportion of these men would actually die as a consequence of their treatment. And remember, this is treatment of a disease that is never going to cause clinical symptoms or death. What I mentioned earlier is that one of the consequences is the anxiety associated with the diagnosis, and it's easy to downplay the significance of this. But studies have shown that rates of cardiovascular disease, specifically heart attacks, and suicide increase in men diagnosed with prostate cancer before any treatment is initiated. So simply being told they have cancer has significant health consequences as a result of the anxiety of having been given that diagnosis. And the same can certainly be a possible cause of harm to our clients, because obviously many of our clients are deeply attached to their animals, and giving them a diagnosis of something that may not be clinically relevant to the patient can do harm to the client. In the case of breast cancer, we also have some pretty good statistics and evidence looking at the direct patient harm, with an estimate overdiagnosis rate of 60% in France in that one study I cited earlier. 80% of the women who were overdiagnosed ended up having radiotherapy. That's 30,000 women having radiation therapy for indolent non-progressive disease. This radiation therapy to that number of women is likely to produce over 800 deaths from cardiovascular disease associated with radiation therapy, and over 200 new cancers specifically caused by that radiation therapy, some of which might very well be clinically relevant, unlike the original overdiagnosis. So for every 2,000 women screened over a 10-year period, one breast cancer death was prevented, because screening can detect disease at an earlier stage and improve outcomes in some individuals. But 10 women were treated unnecessarily for each death prevented, and 200 women experience a diagnosis of cancer, even though that diagnosis is not going to improve their physical health outcomes. So what causes overdiagnosis? Why does this happen? There are several elements to the problem. One of them is behavior on the part of doctors. Another is behavior on the part of clients or patients in human medicine. And then there are the healthcare systems that are set up that contribute to the issue of overdiagnosis. For doctors, a lot of the reason that overdiagnosis occurs is simply psychological. Commission bias is an example of a cognitive bias, a natural human behavior that leads us to make inappropriate decisions or judgments. And it is a bias towards taking action. We really want to do something for our patients. As veterinarians, we feel a strong pressure to take action, to justify the costs that are incurred by our clients in coming to see us, to appear that we are competent and in control and proactive, and just to do the best we can for our patients, because we have this idea that more testing and more screening is almost always to the benefit of our patients. Now that we know that that's not true, that's something we can challenge. There's also some tendency towards defensive medicine. This is obviously a huge problem in human medicine, where litigation is rife. In veterinary medicine, it's less of a problem, but there is a tendency to want to do things in order to protect ourselves against the accusation of not having been aggressive enough later. Then there's just that innate fear. What if I don't do the test and then disease occurs and something bad happens and it's my fault, right? There are a lot of psychological reasons why doctors do unnecessary testing or make overdiagnoses. And a big part of this is spurred by anecdotal as opposed to evidence-based medicine. If we are making decisions on the basis of our own clinical experience, it's easy to get caught up making decisions that are based on limited and unreliable information. So if I say, look, I had a patient once that came in with something really unusual, and I happened to run this test just out of accident or because I thought about it randomly, and I found this disease and I saved that patient's life, and I'm just never going to miss that again. Or I failed to run the test and the patient died, and I'm not going to let that happen again, right? That is a natural tendency for physicians. I've had in my 20-some-odd year career lots and lots of dogs diagnosed with hemangiosarcoma. 2 of them came in because they were limping. And I eventually discovered they were limping because of bleeding from a metastasis of the hemangiosarcoma to a muscle in the leg. So in both of those cases, I was ultimately able to find the true underlying problem, and I was glad because I didn't just send them home with an NSAID and wait to see if they got better. I was able to find that these dogs had cancer. Now, does that mean that I should ultrasound the abdomen on every dog who comes in with a limp, just in case once in a while I diagnose hemangiosarcoma? No, that would not be an appropriate testing strategy. That would lead to a lot of overdiagnosis. But it's understandable that I'm proud of having found those cases and that I'm concerned about missing similar cases in the future. And that kind of psychology tends to lead us towards practices that end up increasing overdiagnosis. And there is, as I mentioned earlier, simply the notion that having a diagnosis cannot by itself be harmful, but it is sometimes harmful to know. Clients also contribute to overdiagnosis through many of the same issues, through psychological predispositions to take action. People may be anxious because they had a dog that died of a cancer they were unaware of, and so now they want to have their dog aggressively tested for cancer at every opportunity, even if that necessarily means diagnosing it with diseases that were asymptomatic and potentially not ever going to be clinically meaningful. Or they may have heard cases like that, where dogs were not properly worked up and not diagnosed, and they want to be more aggressive and do more testing. Taking action, whether asking for or running diagnostic tests or starting preventative therapies, is something that gives us a feeling of control. It reduces our anxiety, that makes us feel like we can avoid bad outcomes that we don't want to happen to our patients or to our pets. But unfortunately, taking action without a good foundation in evidence that shows that action is actually beneficial can lead to a lot of unintended consequences, including overdiagnosis. Healthcare systems are also commonly contributors to overdiagnosis. And one classic example is the development of more sensitive diagnostic tests. PSA, mammography, things like SDMA allow us to diagnose conditions at an earlier stage than we used to be able to detect them. This can be a wonderful thing if we have effective therapies for those conditions, if diagnosing those conditions allows us to provide better outcomes for our patients. But it can also lead to the kind of unintended consequences of screening that I showed you earlier, where we either accomplish nothing beneficial, or we simply induce anxiety in our patients, or we actually create active harm from that diagnosis. Now, there are incentives in the systems for more diagnosis and more treatment. Obviously, laboratories develop tests and then they want to sell those tests. That's what they do for a business. And so they work very hard to find more sensitive tests, and veterinarians are inclined to use them. Veterinarians do generate income by providing diagnostic tests as well, so there is some financial incentive there. In insurance, reimbursement is more of a problem in the human field, but that's another kind of financial incentive. So ultimately, both laboratories and clinicians earn revenue by doing diagnostic tests. And the more diagnosis and the more treatment you do, the more potential revenue you earn. Now, am I saying that veterinarians are simply motivated by money and are not interested in the well-being of their patients? Of course not. That is absolutely untrue. That is one of the most frustrating accusations that we hear all the time. However, I am saying that there is good, strong evidence in human medicine that financial incentives do increase the amount of healthcare provided, that doctors and institutions like hospitals and laboratories do provide more services when doing so raises their revenue. There is an influence on the decisions we make based on the economic conditions in which we work. And that doesn't require any malfeasance or any bad intentions, but it is something we should be aware of if we want to be careful about going in the direction of too much medicine and inappropriate diagnostics or overdiagnosis. Okay, so how do we prevent overdiagnosis? How do we solve this problem? Well, the first step is awareness, and hopefully this is something that you may have heard of before, but many times when I talk to people about overdiagnosis, it's something that they were not aware of at all. So simply being aware of it is, I think, a way of helping us to be cautious about the kinds of behavior that lead to overdiagnosis. Obviously, collecting and analyzing data is really important. As you've seen, we can't ever know in advance in any individual whether a diagnosis we make is going to lead to benefit or harm for that individual. So the only way we know how common a problem this is through collecting the right kind of epidemiologic data. And as you've seen, that is something we do not do very much in veterinary medicine. So that is one thing that is necessary for reducing the impact of this problem. There are strategies that we can employ, even without knowing how extensive the problem is, that will minimize the risk of overdiagnosis. Rational strategies for the use of tests, and especially caution with screening. Being careful about doing diagnostic tests in asymptomatic patients where the things that we diagnose are less likely to actually be clinically relevant than in patients who already have clinical symptoms. Now, one possibility is that there is less risk of overdiagnosis and less overdiagnosis in general in veterinary medicine than there is in human medicine. And why might that be? Well, one obvious factor is that our clients have to pay directly for the services that we provide, and that may reduce their tendency to get unnecessary services. We often are all, as clinicians, faced with clients who can't pay for necessary testing and treatment. So the idea that we may be doing unnecessary testing or more testing than is appropriate seems sometimes hard to imagine given the limitations of financial resources that we're already faced with. So it's possible that the direct pay model that we work with is less likely to encourage overdiagnosis than the insurance reimbursement model. There's obviously also less litigation in veterinary medicine, and that makes us less susceptible to defensive medicine, to running tests simply to avoid the risk of a lawsuit later, and that's certainly something that we have an advantage of over our physician colleagues. There is also less of a demand or supply sometimes for diagnostics and treatments. We have fewer tests than physicians have. We have fewer diagnostic tests and less sensitive diagnostic tests often, and we have fewer treatments available for early stage disease. So the lower quantity of things that can be used to generate overdiagnosis may make it less likely for overdiagnosis to occur in veterinary medicine. Another important consideration is that pets, of course, can't report their own symptoms. So we're really looking for clinical signs in order to say that a pet is symptomatic, whereas in humans, we're simply looking for them to report a symptom. And it is possible that as a result of this, we may not notice clinical signs until a later stage of disease. So even though a pet may seem to be asymptomatic and we may be screening for a disease, we may actually be detecting disease at a stage where a human would already be symptomatic, and we would have a better chance that that diagnosis is clinically meaningful. So the fact that our pets can't discuss their symptoms often means we have to be more aggressive in diagnostic testing, and that that's beneficial in a way it may not always be in humans. There are, however, factors that might make overdiagnosis a greater problem in veterinary medicine than in human medicine. And one I've already touched on several times, which is that we don't collect any data to have any idea how often it actually happens. So we know very little about overdiagnosis and the risk of it. There's not much awareness, and we don't have any data to tell us when it's occurring. I think in general, veterinary medicine, it's fair to say, is less evidence-based and more anecdote and opinion-based than human medicine, primarily because we have less evidence available, not because we're not just as interested in doing good work for our patients, but the research evidence that we have available to use to support our practices is simply smaller in both quantity and quality. And so there are not guidelines and standards of care and insurance company requirements for certain steps that we must take, and it is probable that this makes us more likely to do things just because of personal anxieties or personal experiences that may lead us towards overdiagnosis. As I mentioned earlier, the Choosing Wisely initiative is specifically educating physicians in different specialty areas in how to avoid using certain tests or doing certain treatments that are not likely to be beneficial to patients. There's no equivalent effort in veterinary medicine to help us as practicing clinicians to make the same good choices for our patients. And then finally, there's no restraint on what we can do from the point of view of the insurance industry. As I already mentioned, most of the restraint is on the limited resources our clients may have to pay for services. But at least we don't have insurance companies telling us that test is not useful, that test leads to overdiagnosis, you shouldn't do that. And so that might potentially make us more likely to use tests past a point where it's been shown that they're not actually beneficial to patients. So one example of potential for overdiagnosis in veterinary medicine that I often refer to is pre-anesthetic blood work. And I am not saying, and I'll be clear at the beginning, that pre-anesthetic blood work is never useful or appropriate. I am saying that it is an example of the testing of asymptomatic individuals that can lead to diagnosis of conditions which are truly present but are not clinically meaningful. And it may, in fact, do harm rather than benefit some of our patients. What do we know so far in veterinary medicine about pre-anesthetic blood work? We know that it very often finds abnormalities. Those abnormalities rarely lead to changes in the specific anesthetic or surgical plan, sometimes, but not often. And that having done pre-anesthetic screening is often not associated with a lower risk of complications. There have been a handful of studies on this in veterinary medicine, and so far it doesn't look like doing screening in clinically healthy animals is actually reducing the complication rate. It does seem, however, that doing screening in clinically healthy animals leads to detection of disease that ends up leading them into having more testing and more treatment later. So that is a classic situation where overdiagnosis could be occurring. One of the studies that I referred to from 1997 found that there were quite a few abnormalities, even in apparently healthy animals, when pre-anesthetic blood tests were done. However, the clinical importance of a lot of these abnormalities was unclear. And it seemed likely, based on this one study, that very few patients benefited from clinical blood work prior to, and it seemed, at least in this one study, that clinical laboratory testing benefited very few patients. And in fact, some tests had no benefit at all. There was no patients who had a better outcome as a result of having had this test. So at least the limited evidence we have so far suggests that pre-anesthetic blood work may very well be an opportunity for overdiagnosis. And what I think that leads us to is to be aware of the fact that we rely on this test as something that is going to benefit our patients when in fact the evidence suggests that it probably isn't very valuable and often may lead to diagnoses that are not going to help us improve the quality of the surgery or the anesthesia we provide or the overall health of the patient. So a routine policy of pre-anesthetic testing seems unlikely to benefit patients who are clinically healthy based on history and physical exam. It often surprises veterinarians to learn that in fact pre-anesthetic blood work in healthy young adult humans is rarely done and not recommended. The American Society of Anesthesiologists specifically says that in ASA 1 or 2 patients who are having routine, relatively low-risk surgeries, that baseline laboratory work is not indicated and is not a good idea. And that in general, you should base the lab tests you do on a physical exam and a history that suggests the likelihood of a problem being detected in advance, rather than simply screening everyone with the hope of detecting occult or asymptomatic problems. This is fairly standard in human medicine because even with defensive medicine and litigation and all of the problems associated with that, there is enough evidence to make it clear that that sort of pre-anesthetic testing is not beneficial and in fact leads to more harm than good. Now, we don't know very much about the problem of overdiagnosis in veterinary medicine, even with regard to something as specific as pre-anesthetic blood testing. But here's a little bit of data from a 2015 survey on the Veterinary Information Network, which is mostly online active English-speaking veterinarians, largely from the United States and some from Europe and Australia as well, and a few other places. So it's a relatively limited population, but at least within this population, the question that was asked was primarily, how long before a surgical procedure do you require blood work? One option was to say, I don't require blood work in a physically healthy animal before. And in this survey, only 3% of veterinarians chose that option. So it seems that pre-anesthetic blood work is viewed as necessary or appropriate by the vast majority of veterinarians, even though there's very little evidence to answer that question, and what we have suggests exactly the opposite, that it is rarely beneficial. So what's the bottom line? What's really the important thing to take away from this topic? What I'd like you to understand is that overdiagnosis is a real problem that causes a significant waste of resources and direct patient harm in human medicine. It is something that may happen in veterinary medicine, but we don't have the data to really show significant evidence that it actually occurs, or to understand, if it does, how often and what kind of harm might be occurring. So we need to be aware of overdiagnosis. We need to be aware of the factors that contribute to overdiagnosis, the psychological factors and the systemic and economic factors. And we need to collect the data. And this is something that is going to fall heavily on the academics more than on us in clinical practice. But if we are concerned about this and we are aware that this is a problem, we can encourage our colleagues in academia to put effort into researching this so that we can make better decisions for our patients. In the meantime, we need to make judicious and evidence-based decisions about how we use our diagnostic tests. We need to be explicit and clear with our clients about testing and whether we have evidence to say that that testing is actually going to benefit their patients or not. Here are a couple of resources. I've repeated the link that I mentioned at the beginning of the talk so that you can find a list of resources and a bibliography online relevant to this and also to the other talk that I gave today. I've also specifically written a couple of articles that are relevant to the topic of overdiagnosis. One, obviously, is on the topic of overdiagnosis itself, and which goes into how the problem occurs and the evidence for it in more detail. And the other is a more recent article looking at specifically how to make rational decisions about the use of diagnostic tests, particularly screening tests, how you can consider your testing strategy in a new way and perhaps avoid using tests in a way that's likely to lead to overdiagnosis. I would also encourage everyone to read the book Overdiagnosed, Making People Sick in the Pursuit of Health. This was a book by a couple of human physicians that really was instrumental in starting the awareness of the overdiagnosis problem in human medicine and in kicking off a pretty significant shift in how physicians approach diagnostic testing. And I think there's a lot of information and evidence in here that will be useful to veterinarians, even though it's not specific to our patients. It is natural for us as people and as clinicians to think, don't just stand there, do something. It's important that we take action. But I hope that you've learned, or at least opened your mind to the possibility that there are situations in which it is better just to stand there and not to do something. Thank you very much, and I'm happy to answer any questions.